Yet another poisoning video. Let's go. Hello and welcome to MK Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at salicylate poisoning, of course, in pediatrics. If you haven't yet subscribed to the channel, what are you waiting for? Hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment, grab your piece of paper, and let's go. Here's a case study. You have a 12-year-old boy that presented with severe ichthyosis, and he was treated with topical 2% salicylate acid in simple cream applied over his whole body twice a day. So eventually the salicylate concentrate was actually increased to 5% on day 3 and of course 10% on day 5. On the 8th day, he actually developed salicylate toxicity. His blood levels were roughly around 3.3 millimoles per liter. So the topical salicylate treatment was stopped. Intravenous fluids and bicarbonate were given, and complete clinical and biochemical remission was achieved after 2 days. So our diagnosis was salicylate poisoning in dermatological treatment. So what this case study goes to show is that significant percutaneous salicylate absorption can occur, especially when salicylate preparations of increasing strengths are used. So we have to actually keep them at a minimal. So we'll look at poisoning in children in general before we dive into salicylate poisonings. So the important components that we're going to be tackling are, of course, our focused history, our initial assessment and treatment, our supportive care, and our investigations. So every time, remember that poisonings are going to be accounting for roughly about 60% of all poisonings in children that are younger than the age of 6. 90% of them are going to be accidental and are going to be happening at home when you get a caregiver that's being distracted. And most of these poisons are going to be ingested, although some poisons may be inhaled, some may be spilled over the skin, some may be spilled over into the eyes, and some, worse off, can be injected intravenously. Now, when you are taking a focused history, you want to first look at when the events actually happened, the time to which the person actually ingested the poison and the time which they came to the hospital, because time is of the essence. You also want to look at the drug substance that it was ingested. So you should consider multiple agents in adolescents because they tend to take a lot of things. Then, of course, the quantity of drugs or substances that are ingested, so the dosage, and of course the mode of poisoning, whether it was ingested, whether it was inhalation, or whether it was spilled onto a mucous membrane surface. Then, of course, has any treatment been given to this child? Were they taken to a local clinic? Were they taken to a pharmacy? Or what was given to this child? So our initial assessment and treatment, we want to focus a lot on our ABCs. So we manage our airway, we ensure that the patient is breathing, we gain venous access, and of course we perform a quick neurological examination. You can use the AVPU scale, A for alert, V for responding to verbal stimuli, P for responding to pain, and U for unresponsive, and of course expose the child. If the toxin was supposedly on their skin, then of course the child needs to be decontaminated. Of course the child should be placed in a lateral left position, and physical examination including full neurological examination must be offered for this child. Here are some clues that may point you towards certain things. So looking at odors, if you get a bitter odor that's smelling of almond, then you're suspecting that this could be cyanide toxicity. Remember, this is a respiratory poison. If it's garlic smell, you're suspecting arsenic as well as organophosphates. If it's acetone, like fruity breath, you are suspecting your salicylates or your isopropyl alcohol. If it's wintergreen, you are suspecting your methyl salicylates. If it's mothballs, then you're suspecting camphor. Then, of course, you may get some skin findings. You may get a cherry red skin in carbon monoxide poisoning and cyanide toxicity. It may be sweaty in organophosphates and sympathomimetics. It may be dry in anticholinergics. You may have urticaria in allergic reactions. You may have gray cyanosis in methemoglobinemia. Then, of course, you may get some eye findings. Causes of meiosis include things like opiates, phencyclidines. You may also have organophosphates. You may have phenothiazines. Then, of course, you may have causes of mydriasis like amphetamines rather. You may have cocaine, tricyclic antidepressants, atropine. Then, of course, some poisonings may actually cause nystagmus. So you may actually see that with phencyclidines and dilantine. Then, of course, you may get some retinal hemorrhages with carbon monoxide as well as methanol. Then fever is seen in cocaine, tricyclic antidepressants, phencyclidines, salicylates, thyroxine, anticholinergics, amphetamines, and even theophylline. This is just some clues that you may pick up on the physical examination and the associated poisons that are associated with these clinical signs. So our supportive care is going to be, of course, giving this child oxygen via our nasal prongs, 1 to 2 liters per minute, intravenous fluid. So if they are in shock, we treat the shock. We give them a maintenance fluid of 2/3 of their normal requirements. That's a half-strength diarrhea solution in 10% dextrose. Do not cause emesis. In the older textbooks, they actually advocate for causing the child to vomit, but this would actually cause more damage than more good. So gastric lavage is generally not recommended unless if the patient has ingested a potentially life-threatening amount of the poison. And so this procedure must be actually undertaken within 1 hour of ingestion, or you use a large bore cannula to empty the stomach. We should avoid doing gastric lavages in paraffin, alkaline, acidic poisonings, as well as patients that are unconscious, because it's a huge risk of aspiration, and some of these things are very lipophilic and they can actually cross over to the respiratory system and cause poisoning, or rather aspiration pneumonias in the respiratory system. We should also give activated charcoal or medicated charcoal for enhanced elimination for most toxins. We give it at a dose of 1 to 2 grams per kg body weight by mouth or by NG tube. And then, of course, this should be considered if the patient presents within 1 hour of ingestion. But of course, we can still give this to slow the absorption of any toxin that may be left in the gut, especially if the child has also ingested these toxins that have an extended, or these drugs that have an extended release. Then, of course, remember that activated charcoal is contraindicated in unconscious children. It's contraindicated if you suspect GI hemorrhage. It's contraindicated if there is a perforation. Never give activated charcoal in those 3 scenarios. Then, of course, some investigations we would want to do, we would order for urine, vomitus for toxicology, blood levels, we would also order for a clotting profile, blood glucose, you may order for liver function test, electrolytes. Of course, you're going to be seeing that there's a wide iron gap in some of the poisonings like methanol, paraldehyde, iron, ethanol, and even salicylate poisoning. You also order for urea and creatinine whenever indicated. Now, let's now dive into looking at details of aspirin and pretty much salicylate poisoning. Remember that over the decade and over time, most of the poisonings that are due to salicylates, or rather aspirins, have become less common. The reason being, number one, most of these packaging are now put in child-resistant containers. The second thing is that the aspirin has been superseded by other things like paracetamol and ibuprofen. You'll find that a house will have more paracetamol and ibuprofen as opposed to aspirin as a standard domestic analgesic. So that's why these poisonings have become less common. Now, with the exception, this is what I always tell my students, with the exception of rheumatic fever, juvenile idiopathic arthritis, and even Kawasaki's disease, generally avoid giving aspirin in infants, avoid giving aspirin in children, because there is also that potential of developing a severe CNS complication that is referred to as Reyes syndrome, where children that have viral infections and you give them aspirin, they may develop this complication afterwards. So generally, I tend to avoid aspirin in children regardless of the circumstance or the situation. Now, remember that ingestion of greater than 0.15 milligrams per kg will cause symptoms in children. Fatal dose is estimated to be roughly around 0.2 to 0.5 grams per kg. Acute ingestion is actually going to be greater than 150 milligrams per kg, and this can cause severe toxicity. Now remember that aspirin, and actually rather salicylate tablets, are going to be forming bezoars. So this can actually prolong the absorption, it can prolong the toxicity. Now remember that bezoars are pretty much these tightly packed collections of partly digested, undigested material that are commonly formed in the stomach. So you may get this bezoar of, let's say a child swallows 10 or 50 tablets of aspirin. They'll clump together and form these bezoars that are just going to be releasing slowly into the bloodstream. Then of course you may get some chronic toxicity that may occur over several days or even more with higher doses, higher therapeutic doses. And it is quite common in adults. In children, not so common, because unless if the child is having rheumatic fever or those other two conditions that we mentioned earlier on, we don't really prescribe aspirin in children. Of course, this is going to be undiagnosed and it's often confused, and most of the times it's more serious than the acute toxicity. Now remember that salicylates are going to be ingested in the form of aspirin, which is acetyl salicylate. This is often accidental, but sometimes it can be given by therapeutic intent, by parents. It can be given by therapeutic intent by even the doctor, but generally I would want you to avoid aspirin. There is something that's known as oil of wintergreen, which I've put here as a picture on the right, which is methyl salicylate, and this is actually a source of salicylate, a very dangerous one. These are like topical creams, or rather ointments that you can apply over the skin. Now 1 teaspoon of this is actually going to be containing 4 grams of aspirin. Those are dangerously high levels of aspirin. Now remember that most of these concentrated and toxic forms of salicylates are going to be found in oil of wintergreen, which is methyl salicylate, which is a component of ointments or liniments. And then of course solutions are going to be used also in hot vaporizers. Now ingestion of even less than 5 mils of this solution can actually kill a young child, and any exposure should be considered quite serious. You may also have bismuth subsalicate, which can be used in management of ulcers. If you ingest, it consists of about 8.7 milligrams of salicylate per mil. This is another potential unexpected source of large amounts of salicylates. Now, what's the pathophysiology? Remember that salicylates are pretty much going to be impairing your cellular respiration. So they're going to be uncoupling oxidative phosphorylation. Now, I'll take you back into biochemistry. Remember, you have glucose that's going to be needing to be broken down and releasing the energy in the form of ATP. Now, remember that glucose is going to be entering the process of glycolysis, which has 10 steps, and then eventually is going to yield pyruvate. Then of course, the pyruvate is going to be entering into the link reaction and then eventually into the Krebs cycle, where it gives off certain compounds and a few ATP molecules. But eventually, the bulk majority of the ATP is going to be made in the mitochondria through a process that's known as oxidative phosphorylation, or you can call this as the electron transport chain. Now remember that there are some enzymes, they're a group of enzymes, they're a group of proteins that are essential for this electron transport chain. Now whenever you get uncoupling of this oxidative phosphorylation or the electron transport chain, the bulk majority of the ATP would not be synthesized in the cell. So it means this cell is going to be ATP deficient. Now because this cell is ATP deficient, remember that most of the respiration is now going to be happening via anaerobic terms, and remember that anaerobic respiration results in the production of lactic acid. So this can actually culminate in lactic acidosis. So this can actually cause a primary metabolic acidosis. Then alternatively, the salicylates actually are going to be stimulating the respiratory centers in the medulla. Now, remember that if you stimulate the respiratory centers in the medulla, you're going to be having an increase in the respiratory rate. This child is going to be pushing out more carbon dioxide than they are retaining in their body. So there's going to be that carbon dioxide washout. Now, remember that carbon dioxide in the body is going to dissolve in water in the presence of carbonic acid to form in the presence of carbonic anhydrase rather, to form carbonic acid, then the acid is going to dissociate into hydrogen ions and bicarbonate ions. Now remember that this is going to be essential for maintaining the pH. Now when you're losing a lot of carbon dioxide, you're losing these hydrogen ions. So it means that even the pH is going to increase from the normal 7.35, between 7.35 to 7.45. So it may sometimes get a primary respiratory alkalosis. More often you get this in children as opposed to the acidosis. But remember that even the salicylates on their own can cause a primary metabolic acidosis through the inhibition of the cellular respiration. Now eventually, as the salicylate is actually going to be disappearing away from the blood and entering into these cells and poisoning the mitochondria, primarily you're going to be having a metabolic acidosis like I already explained. Now these salicylates can also cause things like ketosis, which is using ketones as an alternative source of energy and forming these ketones, because pretty much you can't really utilize the glucose because you have uncoupled the oxidative phosphorylation. Now remember that if you can't utilize this glucose and you form these ketones, they can actually be excreted in the breath. That's why we get this fruity breath, the acetone in the breath. You may also get a fever. You may also get even though you may not get systemic hypoglycemia, though it has been reported in some cases, you do get low levels of brain glucose. Then of course the amount of sodium, potassium, and water that is excreted from the kidneys is going to be increased, but this is going to be coupled with, of course, the water loss from the increase in the respiratory rate. Remember, if someone is hyperventilating, they're losing water from their lungs, they're losing water from their body. So this is also going to be contributing to the dehydration that we see in these cases. Now remember that salicylates are actually weak acids, and weak acids, ionized substances, do not readily cross the lipid membrane unless if they're in an acidic environment. So remember that if a weak acid is placed in an acidic environment, it won't give off that hydrogen ion so that it becomes ionized. So it will remain in an unionized form. It's not an ion, it's not charged. So this makes it easier for it to actually cross over the membrane. This is just simple basic pharmacology. Now, so it means that if the pH is lower in the blood, we're going to be worsening the salicylate poisoning. So it means any drug that is going to be causing excretion of bicarbonate in the urine, like acetazolamide, is going to worsen the toxicity of salicylates. You may also have dehydration, hyperthermia, and chronic ingestion, which is going to be increasing the toxicity of salicylates and actually is going to be resulting in greater distribution of these to the tissues. Now remember that because this is a weak acid, so how we're going to be doing this, because remember everything is going to be filtered out in the kidneys, the uncharged particles are going to be reabsorbed back into the bloodstream if they have transporters. Those that are charged remain in the urine. So those that are water soluble remain in the urine and they're excreted in the urine. Now the whole goal of us trying to excrete this aspirin from the body is we want to make it charged. How do we do this? We increase the pH of the urine, because if we increase the pH of the urine and we make it alkalinic, the aspirin or the salicylates will lose those positive hydrogen ions, and then they will become charged, they will become ionic, and they will remain water soluble such that they won't be easily reabsorbed back into the bloodstream. So one potential way in which we can treat these patients that have salicylate poisoning is, of course, alkalinizing the urine. Now, what are some of the clinical features? You have acute overdose, which is going to present to you as early features like nausea, vomiting, tinnitus, which could be very difficult to elicit from a very young child. Tinnitus is just this ringing sound that you have in the ear. Then you may have hyperventilation, you may have double vision, you may have feeling of fainting. Now, late symptoms are going to include hyperactivity, fever, you may have confusions, you may have seizures, you may have rhabdomyolysis, which is breakdown of the muscles, the skeletal muscles. Now remember that when you're breaking down these skeletal muscles, they're releasing myoglobin. Myoglobin is very toxic to the kidneys, so it may be released in the urine, causing the urine to darken. It may also cause acute renal failure. And then, of course, eventually respiratory failure is going to develop. So these children may actually start off as being hyperactive, then eventually they quickly progress to lethargy and eventually coma. Then, of course, they may have this hyperventilation, which is going to be giving us a primary respiratory alkalosis, but eventually they will progress to hypoventilation, where there will now be a mixture of respiratory and metabolic acidosis, and then eventually respiratory failure. Now, in chronic overdose, the features are rather non-specific and may actually be just suggestive of sepsis. So there will be some subtle confusions, there will be some changes in the mental state, there may be some fever, there may be some hypoxia, non-cardiogenic edema, you may have some dehydration, lactic acidosis, even hypotension. Now, what you really need to note is that in any child that actually presents with rapid, deep, regular acyanotic breathing or air hunger, it's almost diagnostic of salicylate poisonings. Of course, you should weigh the scenario. If the parents are coming in claiming that this child took something and they are presenting to you with these symptoms, then you should suspect salicylate poisoning. Now, cases are often misdiagnosed as pneumonias. However, in pneumonias, you get these short grunting respirations. And the children with salicylate poisoning are actually going to be showing peripheral vasodilatation until near death. And then when death is about to happen, they're going to be showing cyanosis, they're going to be twitching, and there will be rigidity, and then eventually they'll slip into a coma. Here is a table summarizing some of these symptoms according to the systems. You have general symptoms like hyperpyrexia, profuse sweating, dehydration, CNS symptoms like delirium, seizures, cerebral edema, coma. You may also have a Reyes syndrome. Respiratory features like hyperventilation. Eventually, they may have hypoventilation and respiratory failure. GIT symptoms like epigastric pain, nausea, vomiting, upper GIT hemorrhage. You may also have acute hepatitis. Renal complications like acute renal failure. In the metabolic system, you may have either a low, a normal, or a high blood glucose level. The anion gap is going to be increased, so it's going to be pointing towards metabolic acidosis. You may have hypokalemia. In the cardiovascular system, you have, of course, your non-cardiogenic pulmonary edema. Then, of course, which I presume should have been added under the respiratory system. But anyways, so the investigations that you may order: your full blood count, your blood, urea, and your serum electrolytes and creatinine, your liver function tests, your prothrombin, your partial thermoplast time, your random blood sugars, and of course your arterial blood gases. Now, we want to order our serum salicylate levels at least 1 to 6 hours after the ingestion. You should order them as quickly as possible. Now, the serum salicylate levels should not be drawn at least should be drawn at least a few hours after ingestion, so ideally within 1 hour to 6 hours. Now, you should also order for urinalysis to check the pH of the urine, because you want to aim to alkalinize the urine. Then, of course, serum electrolytes, creatinine, urea, and glucose, which may be normal, high, or low, like I already mentioned. And then, of course, when you order your arterial blood gases, remember that primarily you may have a respiratory alkalosis in the very first few hours, because there will be this hyperventilation that this child has. But later on, there's going to be a compensated metabolic acidosis, or even a mixed acidosis, metabolic acidosis with respiratory alkalosis, because of the effects of the aspirin that are now getting into the mitochondria and inhibiting the oxidative phosphorylation. Now, as the salicylate levels actually begin to decrease, the poorly compensated or even uncompensated metabolic acidosis is going to be our primary findings. Then that's because only it's entering into the mitochondria, it's blocking the oxidative phosphorylative phase. Then, of course, if the respiratory failure is going to be occurring, the arterial blood gases are going to be showing a combined metabolic and respiratory acidosis. There is going to be a chest x-ray that's going to be showing you diffuse pulmonary infiltrates. We should also suspect rhabdomyolysis when you see dark urine, so you should order for serum creatinine kinase and as well as urine myoglobin. Now, here's a nomogram for acute poisoning. So when you actually get a child that has been poisoned with salicylates, I know this is not really a perfectly pictured diagram, but this is the one that I could find in the quickest space of time. Now, let's say the child has ingested it after 6 hours, which is when you want to take your blood levels. Then if it's after 6 hours, then you can plot it out here. You have milligrams per deciliter. You plot it out. Let's say if they have 50 milligrams per deciliter here after your 6 hours, then this is mild. If they have somewhere around 70, this would be moderate. If they're somewhere around 100 milligrams per deciliter, then this could be severe. So this is a very important graph to plot, because it helps you now look at what type of management you're going to be offering to this child, which we'll talk about very shortly. So how exactly are we going to manage this child? Number one, we want to admit this child. Number 2, we want to do our ABC, so we place them in the left lateral position. We give them oxygen 1 to 2 liters per minute, intravenous fluid, so we treat any shock. Maintenance fluids is roughly around 2/3 of the normal. That's a half-strength diuresis solution in 10% dextrose. But of course, this is dependent on whether this is mild, moderate, or severe poisoning. I'll talk about it in the slides that are coming up next. Then, of course, we treat any hypoglycemia with 5 mils per kg of 10% dextrose. We treat any fevers with physical methods like external cooling. Any seizures that are happening, give benzos. Then if they are having any vitamin K, or rather if they're having any hypoprothrombinemia, then give them vitamin K. Activated charcoal is also a very good option to give these people, especially in the early phases of ingestion, 1 gram to 2 grams per kg per dose, 4 to 8 hourly. Then of course you should plot the salicylate levels on the INURMOGRAM like I told you earlier on. Then the alkaline diuresis with extra potassium can be given, plus or minus hemodialysis, which we want to really reserve for special cases of patients that have severe toxicity and other indications that I will mention later on. Then of course in patients that have rhabdomyolysis, we want to adequately hydrate them, monitor our urine output, alkalinize the urine because this may help prevent the renal failure. So what about activated charcoal? Remember that this is given unless if there's a contraindication like a GI bleeding, an altered mental state, then this should be given as soon as possible. And if you still have the bowel sounds that are present, you can repeat this after 4 hours until the charcoal appears in the stool. So the dose is roughly about 1 to 2 grams per kg per dose. You can give it orally or you can give it via nasogastric tube. That's 4 to 8 hours. Now, when it comes to alkalinizing the urine, which is known as alkaline diuresis, we pretty much want to increase the urine pH so that we can enhance the excretion of the pretty much the salicylate from the blood. So we want to aim for a pH, a urine pH that's at least 8 or more. Now this is going to be indicated in patients that have any symptoms of poisoning, and we shouldn't actually delay getting back the levels of salicylate from the labs to delay this process. We can actually initiate this process much earlier. It's actually a safe thing to do, and exponentially actually it increases the salicylate excretion from the blood. Now we're going to be giving solutions that are going to be consisting of 5% dextrosaline and of course sodium bicarbonate and potassium chloride. So we start off by giving 30 mils per kg in the first hour of our dextrosaline plus 1 milligram or 1 mil per kg of 8.4% sodium bicarbonate. Remember, this is going to be 84 milligrams per mil. Then we also give IV furosemide 1 milligram per kg per dose after the first hours. Then we give it 8 hourly. Then we continue in the next hour. So you're going to give this as an infusion over an hour. Then of course we continue with the 10 mils per kg per dose till the salicylate levels have now reached our therapeutic level. So it's not like you just be giving and forgetting about this child. You'll be giving and you'll be constantly monitoring our levels of salicylate closely. Then of course we add 1 gram of potassium chloride, or rather you can use the millimoles if you want, to each 500 mils of 5% dextrosaline to the above regimen. We should discontinue the potassium chloride if it's greater than 5 millimoles per liter, and we aim to get a pH that is greater than 7.5 and a urine output that is greater than 3 to 6 mils per kg per hour. That's how you know that you're actually doing something that is working. Then of course monitor the serum potassium, the red blood, the random blood sugar levels, the arterial blood gases levels, and then of course do this every 8 hours. We can actually monitor them more frequently in the severe poisoning, and then because of the risk of fluid overload and pulmonary edema, you want to be checking the respiratory system and examining the respiratory system at regular intervals. Roughly you could do this every hour or even much shorter if you're infusing these things very quickly. Then of course avoid drugs that are going to increase bicarbonate excretion in the urine. Like I said, acetazolamide, this may actually worsen the acidosis, and of course it may decrease the blood pH. Then of course the drugs that decrease respiratory drive should also be avoided, and if possible, because they are going to be impairing with the hyperventilation and of course the respiratory alkalosis, that's going to be decreasing the blood pH. Then we may, in some cases, offer hemodialysis. It may be required actually to enhance the excretion of the salicylate, especially with severe neurological impairment in patients with renal as well as respiratory insufficiency, acidemia, despite you using all your routine measures. And then, of course, all patients that are intubated should ideally be dialyzed and closely monitored by a critical care specialist. Now, indications for hemodialysis include the severe cases, refractory acidosis, renal failure, non-cardiogenic pulmonary edema, as well as severe CNS symptoms like seizures. Here's a table to actually grade now the severity and the treatment that we're going to be giving. So those that have plasma levels less than 350 milligrams per liter, this is 250 milligrams. So if you're changing this to deciliters, I think this should be around 35. So you're just pretty much going to encourage oral fluids. There's no need to give bicarbonate. There's no need to repeat the dose of activated charcoal. There's no need for hemodialysis. Those that have greater than 350 milligrams per liter or 35 milligrams per deciliter, so I could say 35 to 70. So these you want to give IV fluids, so pretty much 2/3 of your normal requirement. And then, of course, give them also sodium bicarbonate, as we mentioned earlier on. Give them activated charcoal. There's no need for dialysis. Those that have severe salicylate poisonings, those that are greater than 70 milligrams per deciliter or 700 milligrams per liter, then, of course, we want to give them our IV fluids, 2/3 of the normal requirement. We want to give them sodium bicarbonate. We want to give them activated charcoal, and we want to administer hemodialysis on these patients. Now, the prognosis of the condition, remember, largely depends on the presence of coma, the presence of severe metabolic acidosis, together with plasma levels that are greater than 900 milligrams per liter. That's around 90 milligrams per deciliter. These are going to be all indicative of severe toxicity and, of course, poor prognosis, even despite you giving intensive treatment to these patients. I really hope you learned a lot from this episode. If you did subscribe to the channel, I do enjoy looking at the number growing and growing as we are on our way to 3K. That's the next target by next year, obviously. Then, of course, if you do enjoy these, tell a friend to come and watch them on the channel. My name is Dr. Moses Kazevu, to Zambia and beyond. Until next time, bye-bye.